All right, so this is a combination of chapter 38 and 39. So this is about antibiotics. So there's some underlying principles of antibiotics that I guess bacteria in general, that I'm sure you've learned the difference between gram-negative and gram-positive, cocci, bacilli. I mean, you can spend a lot of time differentiating which antibiotics are really good for gram-negative, which antibiotics are really good for gram-positive. We typically think of them as what is a good infection that they treat, and then what are some safety issues associated with them. So that's kind of how we'll approach this. All right, so we have community-acquired infections and healthcare-acquired infections. Healthcare-associated infections are also called nosocomial infections. So if you see that, so this is like, I went into the hospital, I couldn't pee, I got a catheter, and then I developed this really bad urinary tract infection. So these typically occur after admission to the hospital, and they're a big deal because they affect how Medicaid and Medicare pay for the patient's stay here. So there's, I'm sure you'll learn how to insert a Foley, how to change a central line dressing. I mean, all those things are really, really important so your patients don't get infections, but it really kind of has a wider scale impact. These patients who come into the hospital should not get infections, right? We should be using sterile technique when we need to, clean technique. We should be washing our hands with soap and water. If somebody has Clostridium difficile or C. diff, it's a really, really bad diarrhea. It can be transferred from our hands to another patient. So there's a lot of things, and this is why it's just so important to learn standard precautions and your airborne droplet precautions, things like that. Okay, so superinfection, I do need you to know this. So this occurs when we give somebody an antibiotic and we get rid of all the good bacteria in their body and something bad overgrows. So we have normal bacteria in our body, all over our body, that's really there just to keep us safe. So we have a good bacterial balance. So this is, when somebody gets an antibiotic for whatever reason, and then they get a yeast infection. So this is a super infection. So we don't have that normal bacteria to help prevent an infection. So we can get things like yeast infection or Clostridium difficile, like I was talking, C. diff. So we can get kind of this colitis, this irritation of our gut. All right, and then we'll talk about kind of what treats this, especially MRSA. These are organizations, these multi-drug resistant organisms are organisms that are resistant to one or more classes of antimicrobial drugs. So these are like methicillin resistant Staphylococcus aureus, vancomycin resistant Enterococcus, carbapenem resistant. So these are drugs that have these are bacteria that have basically developed, they've adapted over time so they can fight the antibiotics that we normally give to them, right? So we normally give penicillins like methicillin to treat a staph infection. That's what it is. And the bacteria has become so resistant, so it is now resistant to the drug we used to give it. So that's kind of a big thing, is these drug-resistant organisms, because at what point is the bacteria going to evolve so much that we can no longer treat it? So you can kind of see in here, methicillin, vancomycin, we'll talk about that, carbapenem, beta-lactamase. So these are all, the bacteria have built up resistance to these different antibiotics. Okay, now I need you to write this down as well. So before we start antibiotic therapy, so before we give an antibiotic, a lot of times we need to culture. So culturing, so I had a patient yesterday that I worked. It was 8 hours. It was a long shift, but so yesterday I had a patient who, she had a knee infection. So she was getting an antibiotic for a knee infection. So the orthopedic doctor took a culture of it. So he got a sample of where they thought that infection was happening so they could send it to the lab and grow it. And that's really what they do. They grow it to see what bacteria it is. So we're not going to get cultures on every single patient. But if we're going to get cultures, if we need to get cultures, which whoever the provider is going to decide, if they think you need to get cultures, you need to do that before the antibiotic therapy is started. So that culture was obtained prior to me giving Zosyn and vancomycin, which are 2 antibiotics. So just note that you need to get cultures before you start the antibiotic therapy. All right, so I don't need you to know this for the exam, but we can kind of address infections a few ways. So empiric therapy so we'll start treating the infection before we get the culture results back. So that lady, nobody knew what was in her knee, but they were treating her for MRSA with vancomycin, which we'll talk about, before they get the culture results back. So the culture results typically take a few days. The lab will kind of put these little discs in so they'll know what antibiotic is going to be the most effective antibiotic. And then prophylactic therapy is when we give somebody antibiotics before surgery to prevent an infection. So sometimes you'll see antibiotics being administered prior to surgery. There's no infection at that point, but it's to prevent infection. All right, so a few classes. We'll go over these each individually of antibiotics. So our sulfonamide antibiotics, so this is Bactrim, if you've ever been on that. So sulfamethoxazole and trimethoprim is a combo of that. So this is going to work, on this pathway to prevent synthesization of folic acid, to help the bacteria. I don't need you to know that. It is contraindicated in patients who say they have a sulfa allergy. So this is a sulfa antibiotic, so you would not give it to those patients. Some patients can get a rash and photosensitivity, so sensitivity to light. So you'd want to tell them to avoid hours where the sun is the brightest, wear a hat, wear sunscreen. And then there's some interactions there as well. So this is Bactrim. So with our sulfonamides, we need to drink a lot of water. So you would encourage your patients to drink 2 to 3 liters of water in a 24-hour period. So these drugs can impact the kidneys. So if we hydrate and remain hydrated, the hope is that it wouldn't hurt the kidneys. It's recommended to assess the red blood cell count before beginning therapy and to take the oral doses with food. A lot of these antibiotics can really make you nauseous, patients upset to their stomach. So some of them it's recommended that we don't give with food, but a lot of times if there's GI upset, we tell them to take with food. All right, so classroom response question. A client diagnosed with acquired immunodeficiency syndrome, so this is AIDS, is being treated with trimethoprim and sulfamethoxazole for this pneumonia. Which intervention should the nurse implement related to the administration of these medications? So monitor for hypoglycemia, monitor intake and output, and encourage fluids, administer the medication with the client lying down, or advise the client to limit alcohol for 3 weeks after the treatment is complete. So on the last slide, we talked about encouraging fluids to prevent nephrotoxicity. So that's why you would do that in this case. All right, so with our beta-lactam antibiotics, so these are penicillin, cephalosporins, carbapenems, and monobactams. So these are going to basically prevent the bacteria from making a cell wall. But like we saw in that slide about multi-drug resistance, some of the antibiotics can actually the bacteria can make beta-lactamase. So beta-lactamase kills these beta-lactam antibiotics. So the genius scientists have made a beta-lactamase inhibitor. It's like a little strong army to go with the antibiotic to prevent that. So that's kind of how they've overcome drug resistance in one case. So penicillins are one of the oldest antibiotics. So these are psyllins, so penicillin, amoxicillin, ampicillin drugs. A lot of people will say they're allergic to these. So if somebody says they're allergic to something, do not give it. If a prescriber prescribes it, you would want to talk to the prescriber about it. Say, hey, did you see that this patient had penicillin allergy when you prescribed this? And they may say, yeah, it's okay. I would just document that conversation. So the allergy could be like rash, angioedema. People could go into anaphylaxis, so be mindful of that. And like we talked about last week with the birth control, penicillins can make the birth control less effective. So you'd want to tell these patients to do what? Use a backup method of birth control. So again, allergic reactions, so penicillin and sulfa are two of the biggest ones you're going to see. People can have that anaphylactic reaction. You want to ask them, what is your reaction? So what happens when you take penicillin? And I'm going to tell you, a lot of people will say, well, I don't know. I was just told never to take it. And you say, okay. And I always say, I'm sure people don't find this funny, well, let's not start now. Let's not start taking it now. I do get some smiles, though, so that's worth it. All right. So hypersensitivity reaction, just like we talked about. So think about, anybody having an allergic reaction, they are going to get hives, wheezing, they may get swelling in the mouth and throat, and makes it difficult to talk, anaphylaxis, itching, and rash. All right, so like we talked about, we have these combination penicillin and beta-lactamase inhibitors, these strong antibiotics. So like I was saying, I gave that lady yesterday some Zosyn, so it's piperacillin, acillin, and then tazobactam that's going to help make that stronger. We have amoxicillin and clavulanic acid, which is augmentin. That can cause some diarrhea, so tell your patients about that. And then ampicillin and sulbactam. So these are just kind of stronger than if I were to just give, an amoxicillin by itself. So these are kind of these combo things. And then penicillin, you want to tell your patients to take it with a full glass of water, not juice. Typically, if somebody is given an antibiotic for the first time, this is kind of cultural practice, but you would just monitor that patient for 30 minutes. Sometimes I just kind of like delay the discharge process, like, oh, I'm busy, just to monitor them for 30 minutes before they leave, just to make sure they're going to be okay. And then we talked about natural flora in the GI tract, so they may get a super infection like C. diff, and then you want to recommend a backup method of birth control.